Welcome, everyone, to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning at the University of Alberta and Obesity Canada. My name is Denise Campbell-Scher, and I'm the Associate Dean of the Office of Lifelong Learning, as well as the family physician here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new Clinical Practice Guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work. Just before we begin, I'd like to go over a few administrative items. First of all, we really would want to acknowledge that we're on the traditional territories across Canada of many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. If you have questions pertaining to technical difficulties, L3 or Obesity Canada web programs or services, please use the chat box in the middle of the black bar on the bottom of your screen. If you have questions for our panelists, please use the Q&A feature of the webinar, also located on the right part of the black bar at the bottom of your screen. Our panelists will answer several questions following the oral presentation. Some questions may be responded to through text in the Q&A window. You can at any point use the Q&A button to submit your questions. We anticipate many questions, so please review what's already been asked and upvote those questions you'd really like to see answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be available next week, and it will be sent to you via email. All of those who registered will receive the link. This link is for your personal use and is not to be forwarded or shared. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn additional certified credits by completing a linking to learning exercise. We would be really grateful if you would consider scanning this code and contributing your experiences with obesity management. This will really help us inform our advocacy and programming. It should take no more than 5 minutes to complete, and we're trying to get as many entries as possible to really have a view of what's happening in Canada. So it is my very great pleasure today to be able to introduce Dr. Michael Vallis. Michael will be presenting on the effective psychological and behavioral interventions for people living with obesity. Michael is a health psychologist and associate professor from Dalhousie University. He earned his Ph.D. from the University of Western Ontario in London. He has developed a Behaviour Change Institute, which is a training program for lifestyle counseling skills for physicians, nurses, dietitians, and other healthcare providers. His areas of expertise are obesity, diabetes, gastroenterology, and cardiovascular disease. He's active in research, teaching, and consultation. So I'm going to turn this over to you, Michael, to lead us off and learn all about the behavioral interventions. Thanks.
Awesome. Thank you very much, Denise. It's really a pleasure for me to present these guidelines. It's been quite a journey for us. As you know from Sean's presentation, it's been a real endeavor to review the literature and to present some guidance to the field. I'm really excited about presenting these guidelines to you from the psychological and behavioral aspects of management, because we've really accomplished a lot since our last guidelines were released. And I'm hoping that you will agree that our current approach might actually be really significantly different. I'd acknowledge my co-authors on this particular chapter, David Macklin, who will be on the panel, and he will help me with the questions at the end, and Shelley Russell Mayhew, who is unable to be here today. Next slide, please. So I want to make a couple of contextual comments just so that we're on firm ground. So my first comment, as you see here, is that obesity is a chronic medical disease. So what does that mean for us all? It means that we need to get over ourselves. We are not the most important person in the room. It's much more important what the individual we're working with, their adherence depends on the choices that they make outside of the clinical context. So the fundamental aspect of implementing psychological and behavioral interventions is that we really need to move away from teach and tell where we're the expert, and then our job is to do an assessment, to come up with a diagnosis, to then determine a treatment, then tell the person what to do, and then measure how well they do. Because this expert stance creates the context for bias. It makes you dominant, and when a person in a relationship takes a dominant stance, then you can expect the person, if they want to stay connected, will become submissive. And so this is a very incongruous dynamic from a change perspective. Where we need to move towards is collaborate and empower. And I'd like you to think about that primarily by the following two comments, which is, first of all, if you have anything that you think is worth saying, ask permission to say it, so that the individual will let you know whether they're ready to hear it, what their attitudes are, and you can take those into consideration. And the second is really, once you've heard something, to summarize it, because that's the way in which the patient can really find and achieve common ground with you. Next slide. This is a build slide. So we know that the sort of context is that diet and exercise equals weight loss. This is the current assumption in the field. And we all know that coming into this, that in fact, this is a very false narrative. And I'd like you to think about this importantly, because we need to determine what is it that the intervention is. So psychological and behavioral interventions to support obesity management. Diet and physical activity, which is the outcomes that we're trying to achieve, are actually not what we do. So if you think about this statistically, the interventions are something that we do, behavioral interventions, we do something, and those then have an impact on hopefully improving nutritional behaviors and improving physical activity behaviors and improving medical adherence behaviors. And all of these will contribute to improved health, function, quality of life. But then the biggest question becomes, next build, what are these behavioral interventions? So and this has been reflected in the literature. When we started our literature review, when you saw research done 10 or 15 years ago, it was all about behavioral interventions were telling people what the physical activity and the eating goals were for the patients, and then hoping that they would stick to them. Whereas now we see behavioral interventions very, very differently. Next slide. So with these comments in mind, we really approached psychological behavioral interventions with the following questions in mind. First, are psychological behavioral interventions effective? And if they are, which interventions seem to be effective? And what are the mechanisms of action of effective interventions? And then what factors may moderate the effectiveness of behavioral interventions? So this was the framework by which we did our literature review and really culled the literature for evidence. Now, the thing about the behavioral chapter that made it a little bit challenging was that on the one hand, we had the evidence, but then we knew that because the guidelines are really designed to help the primary care provider and really to be informing of the patient, then we saw that there was a need to make sure that our recommendations were actionable. And this is why what we've done is we've sort of framed up our review in several ways. First, we conducted a pure evidence-based review. So what does the science tell us about these four questions? And then I'll start with that. And then we came up with recommendations based on those, general recommendations, and then key messages for people living with obesity as well as healthcare providers. So the first question that we asked, as you can see on the slide, it told us that multi-component behavioral interventions implemented by trained individuals, and so this is of course something that is important. And one of the things that we're proud of, I think, about the guidelines is that the guidelines are a living document. And what we mean by that is that they're not just going to be produced and left, that there will be follow-up. And this is where in the behavioral chapter, our intention is to support the training of individuals with a number of learning tools that can help them. But the evidence shows that multi-component interventions are effective in producing modest weight loss, in producing improved health status and quality of life. And these are both at level 1A, grade A, which is of course the highest level of recommendation. Providers can be trained to effectively implement behavioral interventions. And the use of technology, such as interactive websites, mobile devices, are effective as adjuncts. These also make grade A, but level 1B, so not quite as strong as those first two statements. Next slide. So what we need to be aware of, though, is what are behavioral interventions? I just wanted to show you sort of a recent analysis that identifies 40 independent behavioral interventions. So what I'd like you to think a bit about is, as we move forward, how do we as a community become aware of what are these behavioral strategies? How do we actually implement that? And this will be something that we'll drill down into as we go forward. Next slide. These are the references that support this, and you'll have this available on the presentation if you wanted to review it. But what's really nice about this list is that most of these are systematic reviews or meta-analysis, which we know generates the strongest level of evidence. So we're actually pretty confident to talk about the value of behavioral interventions. Next slide. This is perhaps one of my favorite slides because it kind of drills a little bit deeper into what works and why does it work. So you see in red here that a number of specific behavioral interventions have been demonstrated to be effective. And these include self-monitoring, goal setting and action planning, reinforcement management, social comparison, cognitive restructuring, and motivational interviewing. And these specific behavioral strategies have been found to be effective at level 1A, grade A. And then you see in light pink, something that I think is actually really helpful to us as a community, which is we ask patients what to do things, but then what are the markers of success? What would be the mediators of success in a behavioral intervention? Because what we're looking for, of course, is sustained behavior. And the evidence is sufficient to say that we can say that behavioral interventions that increase adherence, the ability to actually follow through, self-efficacy, which is your confidence to overcome the barriers, and autonomous or intrinsic personal meaningful motivation are associated with best long-term outcomes. So this may help us as we implement our treatments to not only come up with an agreement with the patient, but then to measure that in terms of, is the patient able to adhere? How do we alter our expectations to increase the likelihood of adherence? How do we develop self-efficacy and support autonomous motivation? And then the last aspect, next slide, that we had talked about was, what are some of the moderators? And so I'll just kind of walk you through this. So providers should be informed about the powerful neurobiological underpinnings of the drive to eat, food cravings, as well as the power of reinforcement, associative learning. These are limits to what you can expect from behavioral interventions. And this information should be used to establish a non-judgmental understanding of the barriers to change in the individual living with obesity to reduce stigma, and aid in the identification of behavioral goals that are achievable in the context of the strength of this drive. And then within that, we would make the following statements. Behavioral interventions that strengthen restraint or self-regulation improve outcomes, level 2, grade B. Acceptance and commitment therapies are value-added adjuncts to multi-component behavioral intervention. Self-bias is common, may affect outcomes, and so assessing for internalized weight bias is recommended to aid with reducing bias and encouraging achievable expectations. Coping strategies consistent with the principles of cognitive behavior therapy and acceptance and commitment therapy can help mitigate against internalized weight bias. And excessive weight loss expectations do not appear to be a deterrent to behavioral interventions. And the companion to that is that satisfaction with the weight loss associated with improved outcomes can be encouraged as an alternative to achieving specific weight. So those are the evidence that we were able to uncover. Next slide. And then supporting references, sorry, next. And then what we wanted to do is come out using that evidence. What are the general recommendations and then our key messages? So next slide. So we have 4 recommendations as follows. Multi-component psychological interventions that would combine behavior therapy, cognitive therapy, and value-based strategies. should be incorporated into the care plans for weight loss and improved health status and quality of life in a manner that promotes adherence, confidence, and intrinsic motivation. Recommendation number 2, healthcare providers should provide longitudinal care with consistent messaging to people living with obesity to support the development of confidence in overcoming barriers and intrinsic motivation, to encourage patients to set and sequence health goals that are realistic and achievable, to self-monitor behavior, analyze setbacks using problem-solving and adaptive thinking, including clarifying and reflecting on value-based behaviors. Number 3, healthcare providers should ask people living with obesity for permission to educate them that success in obesity management is related to improved health, function, and quality of life, resulting from achievable behavioral goals and not on the amount of weight loss. 4th recommendation, healthcare providers should provide follow-up sessions consistent with repetition and relevance. Repetition is our job. Relevance would be the job of the individual. Support the development of self-efficacy and intrinsic motivation. Once an agreement to pursue a behavioral path has been established, and this could be health behavior and or medication and or surgical pathways, follow-up sessions should repeat the above message in a fashion that is consistent with repetition and relevance to support self-efficacy and intrinsic motivation. And I hope you can see there's a lot of sort of common themes woven together in these recommendations. Next. So now what we'd like to do is just filter these messages for individuals living with obesity and then for healthcare providers. And then we're going to finish by talking about one of the primary targets for the guidelines, which would be primary care providers who may be working in a practice where they're implementing the interventions solo. Next slide. So we would offer the following to individuals living with obesity: the understanding that the goal of behavioral interventions is to promote sustainable changes that increase positive self-esteem and confidence and improve health, function, and quality of life. There is not one pathway to success. Goals should be individualized and be important to the individual. Persons with obesity can benefit from working with a clinician with expertise in behavior change. And sustained behavior change is more successful if the behaviors chosen by the individual are consistent with his or her core psychological values. And so this is our hope that we can guide the patients. For healthcare providers, we have a number of specific messages that we would like to promote. First, all interventions involve behavior. So behavioral change supports should be incorporated into all care plans, be them activity-based, nutrition-based, surgery-based, medication-based. Second, the patient-provider relationship shifts from provider as expert to that of collaborator. Interventions should be evaluated based on how sustainable the behavioral components of the intervention are for the individual. We're very hopeful that this will shift away from the narrative of learned helplessness, where the individual living with obesity tries and fails, and the provider says, let's just find a way of helping you try harder, which conveys this message that somehow it's up to you. We're suggesting that if we shift it from not, here's what we would like you to do, to let's talk about what you're capable of doing, and then building from there. This is a very powerful principle called behavior shaping. Fourth, the person with obesity should be encouraged to build self-esteem and self-efficacy based on achievable results, not idealized hope. And finally, nutrition, medication, adherence, physical activity are the outcomes of behavioral interventions, not interventions in and of themselves. So we're hoping that that will be useful for us as providers in general. We sort of want to also support the individual who might have a solo one-to-one relationship with the patient, an individual living with obesity. And we have some key messages, and then also a little bit of an algorithm that might help. I apologize, it's a little bit busy, and so I'll just take my time going through it. But we had a number of things that we we're hoping could be of benefit to individuals who are working in an individual context with someone living with obesity. And the first is to adopt a collaborative relationship with the patient using principles of motivational interviewing to encourage the patient to choose and commit to evidence-based sustainable behaviors associated with obesity management. And that in doing so, they might consider the use of minimal interventions tools, such as the 5 A's, which you've seen from Sean and Aria, have been incorporated into the guidelines: ask, assess, advise, agree, assist. Third, healthcare providers should ask permission to educate the patient about obesity management success being more related to improved health, function, and quality of life resulting from achievable behavioral and psychological goals, and not just on the amount of weight loss. Or education should be focused around biology, bias, and behavior, asking permission to discuss evidence regarding the biological and environmental factors, including genetics, neuroendocrine functions, and physical and social environments, will provide the context for realistic goal setting and appropriate self-efficacy management. Fifth, consider using the concept of best weight, which is the weight that a person can achieve and maintain while living their healthiest and happiest. And if any of those are compromised, the achievement, the maintenance, the health, or the happy, then that's not an individual's best weight. This education should be offered as a means of reducing self-bias and supporting appropriate outcome goals that acknowledge that weight is not a behavior, and that this will also provide a context to encourage body acceptance. And then finally, educate the patient that success is related to setting achievable, sustainable goals to which the individual can adhere while developing confidence to overcome barriers and fostering an intrinsic motivation to maintain the plan. Goals should impact positively health, function, quality of life. Now, my final slide is really a care pathway that we thought might be helpful and something that would frame up the guidelines intention to support developing competency in the skills of behavior change counseling and addressing the psychological aspects of weight and food and health. And so I'll kind of walk you through this slide, and hopefully you'll see that it could be helpful. I guess I'll say in advance that when we offer any of these types of interventions, we know that in any one visit, this work will never be completed. So it's quite appropriate for the individual to take this apart. One thing that I really like to communicate is it's not finding the time you think you need, it's using the time you have, especially if you're working with a person over time where you have the ability to help them really develop a reframed understanding. So we would begin with your job really of conducting an assessment and making a diagnosis of obesity. And Aria last week went through in great detail how we can really conduct this assessment in a much more sensitive and collaborative manner. From that assessment, we would think that you would come up with some ideas as to what it is that you would recommend to your patient. And this would form your sort of beginning treatment plan. You then ask permission to work with the person to create a management plan. And the individual will either give that agreement or not. And if they don't, then you respect that and ask permission to discuss again at a follow-up visit. And importantly, maybe in a non-judgmental way, explore the reasons why the person may not be ready to have this conversation. A lot of the experience of bias and stigma and internalized bias is that individuals sometimes anticipate criticism from healthcare providers. So when we ask them permission for discussion, they might say no because of their history and they don't want to have another lecture. And so exploring the reasons for no in a non-judgmental way is actually really beneficial. If the individual agrees, then you ask permission to educate and deliver the education as we've described based on biology in order to address the bias issues. And then that would lead into collaborative goal setting that can be set and sequenced, recognizing that goals that are both realistic and achievable are the goals that are going to be more likely to be successful. And then as you and your patient sort of work on those realistic, achievable goals in a sequential fashion, you encourage self-monitoring of behavior in which you analyze setbacks. So always communicate the message that when a person takes on a goal, that doesn't mean that you expect them to be successful. As a matter of fact, you don't. If you and the individual agree that the person's going to try X, Y, or Z, it's the attempt to make the behavior happen that's important. And if it's successful, great. If it's not successful, equally great, because then that will allow you to problem solve and analyze what went wrong. And we know that the behavior change process is often this iterative process of I tried it, it didn't work, or it worked in this circumstance, but not in that circumstance. And when that's examined in a non-judgmental fashion, you can almost always uncover the reasons why it didn't work. And then that allows you to reframe your goals and find a pathway of success. And so then as you are guiding your patient through that, there's also a number of issues that we feel would be helpful from a psychological and behavioral change perspective that would be important. And you can see those are in the light blue here. That don't be surprised if very early on in the journey of supporting someone achieving healthier weight and their best weight, that you may come up with the internalized bias issues, for which the education around the fact that weight is not a behavior and all behavior has limits. And the way I like to say it is just because one person can run a marathon in 2 hours and 1 minute and 34 seconds doesn't mean that everybody should be able to run a marathon in 2 hours, 1 minute and 34 seconds. We have to understand the behavioral limits that anyone would present based on their context. Also, the expectation issues always comes up, and these are very useful to engage in supportive conversations with your patients very early. As the patient begins to engage in behavior, then it's a really useful opportunity to orient them towards values-oriented behavior. And again, primary care settings are wonderful places to do this because most primary care providers know so much about the patient, their family, their context, their history, that they actually have a lot of information that they can use to help the patient clarify what's important for them, what makes the hard work of health worthwhile. And also, this allows us, as we go forward, to really understand the idea of wanting. And one of the things that is supported by the evidence is that eating is not a behavior like other behaviors. Eating is a behavior into itself, and it has a number of specific brain systems that drive eating. And passion and desire are absolutely essential to human functioning. And so understanding how this shows up with regard to eating behavior is actually really, really useful. And this is really where we can take great advantage of what we call associative learning, where all of the cues that elicit the conditioned response of eating can be understood and modified, and also operant conditioning. The next time you hear a person say, oh, they're a stressed eater, it's probably not the stress that's driving the eating, it's probably the reward of food that's helping them manage their distress of the day. So it's an operant conditioning paradigm in which the food becomes the reinforcing value in the context of stressful experiences. And this wanting can then be understood through its counterpart, which is restraint. And we know that the hedonic systems in the brain create the wanting, and the executive functions in the brain allow us to consider our choices and perhaps reflect on whether those choices are the direction that we want to go in or not. And then the final aspect to this model that we would hope would be helpful is to understand that all of this is really modulated by a number of factors, things like, stress of the day, fatigue, depression, anxiety, attention-related problems. And we can encourage individuals to incorporate an understanding of these modulators so that it helps to frame up what their next step goals are. Okay, so in a fairly brief period of time, I have walked you through what we're hoping is going to be a useful sort of staging of what does it mean to engage in behavioral change interventions with your patients. They are intricately tied to the psychological aspect and are very much in the context of what we know about chronic disease management in general. Okay, that's the last slide for me. And I think that Denise is now going to take us through the question and answers.
Thank you so much, Michael, and thank you to everyone who's been already starting the ball rolling with questions, and Nicole for posting some useful links in the chat box to these chapters so everyone can have a look at those links. So we're very pleased that on the panel today, in addition to Dr. Vallis and myself, we have Dr. David Macklin and Dr. Arya Sharma. So Dr. Macklin was a co-author on this chapter with Michael and Shelley, and he's a lecturer at the University of Toronto Faculty of Medicine and University of Toronto trained family physician. David has committed his career to the prevention and treatment of obesity. He's the medical director of the weight management program at the MedCan Clinic. He's also the medical director of the weight management program at the Toronto Mount Sinai Hospital High Risk Special Pregnancy BMI Unit. Arya, do you want to mute? He is a science committee member at Obesity Canada. Dr. Macklin is also a co-author of the recently published Canadian Action Study. Dr. Sharma was recruited from the Humboldt University in Berlin in 2002 to a Canada Research Chair in Cardiovascular Obesity and Management at McMaster University. In 2007, he accepted a position as professor and chair in obesity research and management at the University of Alberta, where he's also the medical co-director of the Alberta Health Services Provincial Obesity Program. In 2005, he spearheaded the launch of the Canadian Obesity Network, which is now Obesity Canada, which has remarkably transformed the landscape of obesity research and management in Canada. His research focuses on an evidence-based approach to management of patients living with obesity and includes development of the Edmonton Obesity Staging System. So thank you everyone for joining us. Delighted that you're able to be here today. There's some questions, and folks, please enter your questions in the Q&A section. Erica is wondering what we think about mobile apps to promote behavioral interventions, like the mobile app launched by the UK called 12 Weeks, and is wondering about the Canadian context for these kinds of tools. David, do you have any thoughts about that? Have you seen anything being used in our context?
Sure, thanks, Denise, and thank you, Michael, for that great talk. I think it's a great question. I mean, are there auxiliary tools that a primary care physician or another healthcare practitioner can use as an adjunct to supporting patients who are living with obesity? Absolutely. Are there currently apps that are effective in Canada from a behavioral perspective? That's still a stay tuned, and those will probably develop over the coming years. One of the points of kind of Michael's presentation today, and this is the hope of our chapter, is that we actually hope to build confidence and efficacy in clinicians in being able to introduce principles of behavioral intervention at the clinical level. So this is rather than outside tools, and there can be outside tools that can support a patient in their weight management, but really here we're talking about intrinsic capabilities in healthcare practitioners to be able to sit across from an individual living with obesity and to be able to introduce key principles of behavioral intervention. We know that the evidence is there that they can be successful and effective, and that physicians can learn and other healthcare practitioners can learn. And so I know it sounds like a little bit of a tangent, but the real hope here is that we are able to, through knowledge translation that will follow, as Michael mentioned, that will be able to empower clinicians to themselves in clinical interactions to be able to support behavior change in patients who are living with obesity.
Thanks, David. Michael?
Yeah,
Yeah, awesome. So this is a great question, and I love the questions. And what I'd like to encourage, so Erica, I also see Andrea has posed a similar question. So what I'd like you to consider is the magic is not in the app. The magic is in what the patient does and the relationship that the provider has with the patient. And so does something like, do these apps work? Well, if the patient uses them. And if the patient uses them and finds them helpful, and then if the patient uses them even when there are barriers, and then if the patient develops personal, meaningful reasons why that technology is of use to them, then yes, it will work. So what we've tried to do in the guidelines is shift it away from what do I do to make my patient change, to recognize, no. Your individual will make their own decisions, and we're there to support them. And these technologies are beneficial to the extent that they support adherence, self-efficacy, and intrinsic motivation. And it's important, these questions, because okay, right now we look at the chat box and we see, okay, we've got a UK app and we've got Noom as an app. Somebody else could throw in another app or two. What about MyFitnessPal? What about? And the response would be, they all would have the same response, which is, if you think it's worth recommending, then I would ask you as a clinician, why? What principle of behavior change do you think this app could help you in? Goal setting, accountability, self-monitoring, whatever, right? Whatever reason you're thinking of, and we would like you to consider from the behavioral chapter, what are those behavioral strategies that are evidence-based? And then how, if you feel that app X, Y, or Z meets that, then you offer that to the patient, you and the patient then have an agreement, recognizing that the magic is not in the app, but it's really in the patient being supported in a understanding, collaborative relationship to be empowered to do something different that is successful and that builds intrinsic motivation and has a positive impact on health, function, quality of life. So I love the question, because we're trying to support it away from a structure and take it closer to a process, which we believe is necessary for any chronic disease management.
That's great. Thanks, Michael. Arya, do you have any insights on this?
Well, not much, except, I want to agree with everything that David and, and Michael have just said. All of us carry a mobile phone, and all of our mobile phones has automatically, the little health app that tells you how many steps you've walked and how many stairs you've climbed. And frankly, I discovered that I had that app on my phone probably, 5 years into having my phone, which means I never use it. Now that I know that there's a lot of people who, open that app and look at it, 40 times a day. So, and absolutely those people might find, those apps very helpful, and they look at the statistics and they use it and they see it as a motivator and they see it as a way of tracking their activity and their health and all that stuff. And it comes down to basically, what we say about diets or what we say about medication or what we say about any treatment. Treatments only work when you use them. And if you have an app and if you find the app helpful, and if it is finding, and you actually have a relationship to, whatever the app is doing for you, and you're finding that meaningful and helpful, well, then by all means use it. But, some people are just not app people. And some people, they do it for a while and then they stop because it just gets boring. It gets highly repetitive. So, as Michael pointed out, the magic is not in the app. The magic is in, finding a way for patients to change those behaviors in a consistent manner, in a manner that helps them being adherent. And if an app can help them do it, and if there are those kind of people who like that kind of support and are open to that kind of support, by all means. So it's not in the app; it's in what you do with it.
Mm-hmm.
So,
Thanks, Arya.
So Denise, I would add, I think just to provide a practical example of this principle. I really like the idea of clinicians looking for tools that are going to help them with their patient and treat their patient. So recommending an app, if we go backwards in Michael's presentation, where we're looking to move to a collaborative relationship and away from a telling and prescribing, relationship with our patients. Here's this really interesting example. So for example, in my clinical practice, I have never told a patient to use an app ever. Maybe in the past I was bad at this and I did, but I certainly won't do that now. So what do I mean by that? That I won't tell someone to use an app? And this is a trap that you might get caught in otherwise. So it's just to share this kind of clinical pearl. So for example, self-monitoring, we know, so MyFitnessPal is an app that helps someone self-monitor and to track their calorie intake and their food intake. And it can be very helpful. And we have evidence, as we saw, that self-monitoring can improve outcomes. So why would I not tell a patient to use MyFitnessPal or some self-monitoring app? Here's the problem. When you look at people and using technologies like technologies for things like self-monitoring, what you see is an incredibly varied population. Some people take on MyFitnessPal and self-monitoring, and 8 years later, you cannot remove the phone from their cold hands. They love it so much, it's working perfectly, it's supporting them, that's in their personality, it's something about them that they really like it. And then we'll meet other people who go home and 2 days later, they have to call Apple Care because they threw their phone against the wall and it busted up because it was the most frustrating experience. And I can't write down everything that I'm eating. I mean, this is ridiculous. Now, what if me as a clinician said to a patient they should self-monitor? And what if they're part of that second cohort? What I've done is I've built a brick wall between myself and my patient because I've told them they should do this. It's not something that they enjoy or that for whatever reason is going to be part of their path forward. And so I've built an obstacle between my patient and myself. And so please understand that when we are encouraging someone to consider things like apps, that I really, appreciate the messaging to come through that really what we're doing is we're advising them that this can be helpful. And then we're inviting them to consider using it and reporting back. Are you someone who enjoys this? Are you someone who this does not work for? Would you consider trying it and reporting back to me, whether this is something for you and whether it's not. So I know that sounds subtle, but it's a world of difference from telling someone they should do this to informing them that it can be helpful and inviting them to consider it and report back whether they really feel it can be part of their path going forward. It's a subtle difference, but it's a world of difference at the same time.
Well, thank you so much, David. Yeah, I think that's a really important distinction. And it's really about the person charting their own course, isn't it? So I just wanted to highlight as well, and I put it into the chat box, that we do have a chapter in the guidelines called Emerging Technologies in Virtual Medicine and Obesity Management that Rick, Dennis, and Lean wrote. And that's the current state of the evidence of some of these technological-based interventions. So if people are interested in this, I'd encourage you to have a gander at that chapter. And yeah, really what they concluded as a key message was that the management through technological means has shown benefit in recent years, as we've just been discussing, and that they can be cost effective and time efficient and flexible. The benefits of them in terms of weight loss have been shown in the literature, but they're saying there's insufficient data comparing these interventions to conventional face-to-face management. And so there's a really nice summary there on the state of affairs. And as we said, this is a living guideline. So as new evidence becomes available, I'm sure this chapter will be updated with all the others. But I think the proof, as everyone has just said, is really in the whole, how are you using this and how does it work for people? So those are great questions, Erica, Andrea. Thanks so much for bringing those forward. So we've got a question here from Rena, who's asking about how different providers can get background to be able to apply these recommendations in the behavioral health skills. And I just want to also just quickly put a little preamble. The reason why the guidelines in this section talk about the solo MD is because in Canada, as we all know, with our massive geographical diversity and heterogeneity across the provinces, there's a lot of variability in to what degree people can actually access interdisciplinary team-based care. And certainly in the guidelines, we're all very, very promoting interdisciplinary team-based care and primary care, but we recognize that there's places where people just don't have that luxury. So when we talk about a solo MD approach in that title, it's actually really a solo practitioner approach, and it could apply to anybody who's working with people and trying to be helpful in the behavioral space when they're not primarily trained in that space. Would that be fair, Michael?
Absolutely. Yeah, I think that's absolutely fair. And really, I think where we're going, both chronic disease in general, but also really obesity management, is to provide the context for some of these strategies. That's why I really like the guidelines, the behavioral chapter this year, as opposed to 2006 when I was last involved in writing the behavioral section, because we really can, I think, describe what it is that is successful for the patient, and then what the principles are that the clinician. So David and Shelley and I are very interested in following up with tools and strategies, putting it into practice much of what, for instance, David's really elegant illustration of the subtle difference of making a recommendation in a collaborative context versus making a recommendation in a directive. I'm the expert, I'm going to tell you what you're going to do, and it should be helpful. He did a great job on that, and these principles really can be reflected, and our hope is that we'll provide opportunities through Obesity Canada, the guidelines to do so. When I created the Behavior Change Institute, the core really is to help us ask ourselves three questions. One is do you have a change-based relationship with your patient? So how do we actually collaborate, work together, and dominate the relationship with the patient's view and the patient's direction? Second, what are we asking the patient to do, and are they ready to do it? And how do we help people really take on the task so that they're increasing the likelihood of success? And then importantly, once you begin the work, how do you organize this work in a way that improves your confidence and your ability to continue to do the work? So these are really the principles that guide. So it's not content-based as much as it's a process-based approach. And yes, I think the guidelines are set well up now to follow up with examples of how we can use these types of interventions to support follow-up work with our patients.
So Michael, Rena's also asking about training and development of skills for both people who are medical professionals, interdisciplinary medical professionals, as well as non-medical people. Could David, Michael, Aria comment on opportunities for skills building? Let's start maybe first for people who are working in healthcare, and then perhaps for patients and their supports as well.
Well, it's Aria here. I can, if I can go first. I think, just listening to Michael again, and I've heard him so many times, but every time I listen, I learn something new. And I think a lot of what he talked about is really a philosophical approach. It's an approach of how do we approach the issue of behavioral change, and what is it that we're actually trying to achieve. And I think those philosophies and those basic principles can be helpful to any health professional. See, whether I'm a nurse who's trying to get a patient to do something, whether I'm a doctor trying to get a patient to do something, whether I'm whether I'm a dietitian, whether I'm an occupational therapist, where I'm trying to work with the client, it always comes down to the same thing. We might have different things that we would like our patients to change in their behaviors, but ultimately we're still talking about behavior change. Whether I want my patient to take their medication or come for an appointment or go for a test, or whether I want a patient to try out a new technique of self-care, whatever the behavior is that I'm trying to get my patient to do, it always comes back to the basic philosophy. I think that Michael outlined so beautifully in his presentation, that at the end, our job is not to do those behaviors, and our job is probably not even to tell patients to do those behaviors, right? It is to support our patients in making behavioral changes that are meaningful to them, because ultimately, if it's not meaningful, and I would add, if it's not enjoyable for them, then nobody likes doing stuff that's not meaningful and that's not enjoyable. I mean, I for sure don't. So I think the basic philosophy of behavior change is something that needs to be in the DNA of all health professionals, and irrespective of whether this is obesity or whether this is any other field of medicine. So I totally agree that I think that the basic skills of behavior change, the theory of behavior change, everything we heard about from Michael, is absolutely a skill and knowledge that I think every health professional needs to have, no matter what area of medicine they work in.
Thanks, Aria. And I mean, Dawn's on the line too. And I know, Aria, at Obesity Canada, you do have your Certified Bariatric Educator course, which I'm sure must include some elements of training on some of these skills. Are there other courses that people could get involved with, or can you comment briefly on that?
Well, if you're asking me, again, of course, we have the Certified Bariatric Educator course, which is open to all health professionals. And yes, there is quite an emphasis on behavior management or behavior change there. And I think, in fact, actually, a lot of that information comes from Michael's work and has been informed by his work. I mean, Michael just mentioned his own institute, which provides training and expertise in this area. And then there's certainly a lot of other sources out there. But again, I think it comes down to the basic philosophy of knowing that the only person who can actually do anything is our patient. And our job is to help our patients and support our patients and motivate our patients and cheer them on and coach them perhaps. And I think that comes, so those are basic skills that I think we all need and that we all need to exercise in our patients.
And this is Michael. I'll just make people aware that if you go onto the Obesity Canada webpage, you'll be able to find the access link to the 5 A's work. And there's been the 5 A's for adults, for children, for pregnancy, weight gain. Denise has really led the 5 A's team approach. So there are actually quite a lot of tools that are available that we can begin to follow and to use access to. And again, we're hoping the guidelines will become a kind of a lightning rod for the continuing conversation around this line, so that there will be a series of sort of sequential learning tools that will allow again, it's the same process. As providers, we want you to be able to find a procedure that you can adhere to, that you develop confidence in your ability to work with even some of the challenging patients, and that you come to see that this is actually what you really want to incorporate into your practice. So very much in the same way we would guide your development along this line. So I think that material would probably be important. Anyone who has a question about training, then I would suggest that you access those and then formulate what your questions are based on any learnings that you can have from those existing tools.
Thanks very much, Michael. Nandini has a practical question around the evidence, and perhaps David, you could tackle this one. She says that often patients want to make multiple behavior changes at the same time. And she's wondering whether there's evidence to show that focusing on one behavior change at a time will improve outcomes versus addressing multiple behaviors at the same time. So do you have any insights on that from the work that you guys did in literature review?
Yeah, the great question. The perspective that's most helpful here is the evidence that tells us that patients are a heterogeneous group, and that we don't know the answer for the individual sitting across from us, whether this is someone who's going to benefit from multiple behaviors being focused on at one time versus one. What's really elegant about the processes that we're communicating is that that's not even our decision. That's the patient's decision. And that's something which we're going to help them discover through, well, addressing. So for example, it's, I loved Rena's question as well. And Rena, just to, even from personal experience, I'd suggest there's nothing written into our chapter and the coming knowledge translation tools that preclude other than medical practitioners from organizing within their practice these behavioral change principles. There's nothing restricting any level of healthcare practitioner. And I've personally experienced registered dietitians that I have the honor of working with becoming really, in a way, world experts at behavioral change principles with their patient interactions. And so to answer Nandini's question a little bit more specifically, here's the idea. The idea is to find out what the patient thinks about it, and whether you're in a collaborative relationship where they believe and understand that you believe and understand that their struggle is real and valid, and your understanding is communicated to them so that they understand that they're in a relationship with a clinician who is going step by step with them and discovering what their obstacles are. So for example, have we communicated to that patient that we believe their condition is real? that it's something that is conferred genetically, centered in the brain, that this is strongly environmentally influenced, and have we countered the internalized bias that likely exists in this patient, where they believe in a shame and blame way that their struggle with weight is their fault and that this has been a moral failure on their part. So are they sitting across from a practitioner who has communicated that that is not your belief? In fact, your belief is the opposite, that their struggle is valid and real and treatment exists for what they struggle with, and they've just never really been treated before. Because if that's the context of the relationship and you've addressed that first module of addressing internalized weight bias, now if they try a couple behaviors or 3 or 4 and struggle, they're able to be more resilient because they're saying, oh, okay, what a great reminder how this is a difficult condition and how taking on maybe too many behaviors for me at this point in my life might be too difficult. And so, you know, would we, in this iterative process Michael described so well, would we consider shifting from what was more difficult, addressing 2 behaviors, to maybe just addressing 1? So I love the answer as being not ours. The answer is really the patient's. And we're setting up an environment where they're encouraged to discover for themselves the answer to that question.
I'll add
Thanks
to that,
so much, David. Yeah.
If I might, great question. Nadine, when you have that question in your mind, think of asking it directly to the patient. So this isn't a question that there's an answer to, because the evidence is actually interesting. On the one hand, we have self-efficacy, which is your confidence in your ability to do the behavior in the face of barriers. So that might suggest, oh, 1 at a time, so you can build that. But then we also have, equally valid, is the behavioral principle of coaction. You start one behavior, other behaviors become easier. So what are you going to do, Nadine? On the one hand, you've got evidence for self-efficacy, which is slow down. The other hand, you have evidence for coaction, so speed up. Well, we just talk to our patients. So for instance, if you're sitting across from a patient who, you know, has a business on the side, they, you know, sort of multitask all the time, they, you know, they love having as many balls in the air as they can, that person may be quite happy to take on a number of tasks, because perhaps we know them and they know themselves to be highly organized, disciplined people who like to have a challenge. If someone else is sitting aside that's really feeling a little bit deactivated or feeling like they have a lot of internalized bias, they don't have a lot of confidence or self-esteem, then we might want to make sure that we encourage those processes to happen first. So they're not a question for us to ask each other what's the right way to go, but they're the questions for us to ask our patients and then match that intervention to the patient.
Mm-hmm. Great. Thank you so much, Michael. That's really helpful. Thanks for the question, Nandini. Michael, we only have a couple questions left, and I think Tio's question, I think we would all agree that the foundation of everything in this space is psychological interventions. So maybe we agree with you, Tio. I think we should tackle Lucia's question, because I think this is such an important question, and really appreciate Lucia. So she's asking about what do we, can we help explain how these new guidelines are similar or different to health at every size? And I just want to chip in on this a little bit myself, Lucia. I mean, I think the key thing with these guidelines is the definition of obesity, which we've framed in the previous talks, which is we would only say that a person has obesity when they're actually having physical or metabolic harms related to their excess adiposity. So if that adipose tissue has now become toxic, it's deposited in the pancreas, it's deposited in the liver, it's doing things to the patient that are contributing to them not being well and not being healthy, that's when we would say that they actually have obesity. If the excess adiposity is not contributing to physical or metabolic harm to the person and they're completely well, then they're healthy, and we would say that they actually don't have obesity. So these guidelines are really focused at the situation where people actually have obesity, and how do we help push the needle to help those people get effective treatment? How do we help people have the skills and knowledge and expertise to be able to be truly therapeutic to them when they show up in clinic, and how do we make sure that those needs are addressed? So that would be my 2 cents on that. Michael, Arya, David, thoughts on that?
Well, I'll make a couple of comments. First of all, I'd have to say that I don't believe that I can speak sort of authoritatively from the Hayes approach. So with that as a disclosure, what I see really as a similarity is that my understanding of the Hayes is that they really have the dignity and the worth of the person at their heart. And I would say that these guidelines are the same, that we also have as our foundation the respect for the dignity and worth of the individual at all sides. I do think where we differ is in whether fat cells are toxic or not, and if they are, then it contributes to a disease process, as Denise has stated. And I think the other is really just meeting individuals where they are. And so if a person is not interested in care, if they are quite comfortable with their position and they have what we call no ambivalence, there's no part of them would like to be different, then we wouldn't insist on change, that we really would see this from a kind of a patient-centered, a person-centered approach. So I would just make those two comments.
Yeah, so
go ahead, Arya.
Yeah, so Arya here. So perhaps in contrast to Michael, I think I'm quite familiar with the Hayes literature. In fact, I've spent a lot of time digging deep into Hayes literature ever since it's been around, because I remember blogging about Hayes probably almost 10 years ago. So I've always had an interest in Hayes and the Hayes philosophy, and I think you'll find a lot of the Hayes philosophy in general terms very much reflected in the guidelines. So, for example, and this might be one of the main examples, is moving away from a numbers-based definition of obesity. So, as Denise just said, we've moved away from a health-centric definition of obesity rather than from a BMI or anthropometric definition, where the focus is really not on the size or the weight, but ultimately is on the basic question of, is this person healthy or not? And does their size or does their adiposity have anything to do with driving that process? So I think that's already a shift that's very much sort of moving towards the Hayes approach or the Hayes philosophy. The other thing that I can see is that when we look at outcomes, traditionally obesity management has always focused on weight loss, and the outcome of successful obesity treatment has actually always been defined by, okay, how much weight has my patient lost? And in fact, one of the problems we had writing these guidelines was that when we started looking at the evidence for a lot of the treatments out there, that evidence or the strength of that evidence was very much based on the outcome or the primary outcome of those studies, and a lot of those studies were actually designed where the primary outcome was weight loss. So when you look at those studies, and that's why you see in a lot of the recommendations, especially if you look at the pharmacology chapter and if you look at the surgical chapter, there is always talk of weight loss because that's what the studies were about. That's what the studies had as primary endpoint, and you can't write guidelines and ignore the primary endpoint of the studies you're trying to discuss. But when you read the subtext, you will see that even in the medication chapter and even in the surgical chapter, the emphasis is not on how much weight does the patient lose. It's always ultimately the bottom line is, are you improving the health of the patient? Are you improving the weight of, the well-being of the patient? And that is the focus. And that's very much in line with the Hayes philosophy, where the primary goal is not how many pounds can I drop in a given patient, but is my patient getting healthier? And you'll see actually in several of the chapters in the guidelines, there's a very clear mention that yes, you can improve the health of a patient by if you improve someone's diet, if you improve their self-efficacy, if you improve their self-esteem, if you improve their mental health status, if you make them more physically active, if you can get all those health behaviors working, you will end up with someone who is much healthier than before, whether they lose weight or not. And you'll find that actually repeated throughout the guidelines. So that is very much in line with the Hayes philosophy. I think where we do perhaps disagree with the Hayes philosophy is perhaps in the idea that yes, weight loss is not the primary goal, but it remains relevant because there are a number of medical conditions where there's a lot of evidence that to actually improve those conditions, you are going to have weight loss. And perhaps the easiest one to understand is the case where you have a mechanical obstruction. If you take sleep apnea, for example, as one of the examples, where because of the excess fat tissue that you have around your neck is making it difficult for you to breathe at night, well, no improving your diet or improving physical activity or improving self-esteem is going to help with the sleep apnea. Ultimately, you're going to have to lose the weight, and that weight has to come off from your neck so that that allows you to breathe. So as much as you can support the Hayes philosophy, and that's just one example, I can think of a whole other bunch of examples where you actually do need the patient to lose weight to achieve the improvement in health that you're looking for. So that's perhaps where there's a disagreement. I think we totally agree with the Hayes approach that using primarily restrictive approaches that are doomed to failure, just setting up the patient for failure, which unfortunately, is what you do when you make simplistic recommendations to patients. I think, is something that, again, you'll find that in the guidelines is not the approach that the guidelines take. There's also some disagreement, certainly with the Hayes philosophy, on whether medication should be used or whether surgery is even an acceptable treatment. Well, it is. If you're trying to induce weight loss and get sustained weight loss because you think that is part of the problem that needs to be solved for this patient, well, then those are the evidence-based approaches on how you do it and how you do it best. So I think there remain a lot of disagreements, perhaps, or arguments, or things where we need to kind of reach out and try to understand the other perspective. But overall, I would say that our current guidelines are very, very much in line with the Hayes philosophy on many levels.
Super. So I'm just mindful that we're 5 minutes over. So I'm going to just thank everyone so much for your participation today, and for the great conversation and questions. We really look forward to seeing you again next week, and which I believe will be pharmacology and surgery. So great lead in for that. Please provide some evaluation if you can the links are on the screen, as well as that QR code for participation in our experience summary of people's experiences, because we really want to learn from you as well. So thank you all so much, and thanks to the team at the Office of Lifelong Learning and Obesity Canada for all your great support, and of course to Michael, David, and Aria for coming out today and supporting us with this important presentation. We've had a number of questions come up over the last while in the previous sessions related to intrinsic weight bias. And so I think it's maybe worthwhile to go back and talk about, in your practices, Michael, David, when you come across a patient who's really internalized that, how do you work with them to help them start to move into a little bit of a different direction clinically?
Yeah, thank you for that, Denise. It's a really, really useful question. And I think my first comment, and then I'll ask David to chip in as well, because I'm sure he can help us with this as well. But my first comment would be for us as clinicians to not become overwhelmed by, opening up what might feel like a very deep well with the patient. We know that that patients really benefit, individuals really benefit from compassionate understanding. And one of the lovely things about collaborative work with our patients is that we don't have to be the only experts. We can partner with them. And so when you see the internalized bias, it's a really, just think about it as kind of a learning paradigm. Just if you've been told all your life it's your fault, then you're just going to assume it's your fault. If you've been told all your life it's you're just weak or you don't have the willpower, then why wouldn't you then just sort of internalize that? Because it becomes the sort of foundation from which you have sort of had your experiences. And so it's really useful to be sort of aware of that, because what we want to do is really help our patients to appreciate the impact that has on themselves. So what I often do is reflect back on what's being said. And so, if someone were, let's say, to say, well, it's like, I'm just weak-willed. If only I had the willpower, I should be able to do this. Other people can do this. There's just something wrong with me. I'm damaged goods. I recognize that. Then, one thing can be kind of useful is, and we call it sitting with, which is some of this important psychological information. There is no magic solution, and nobody's looking for a magic solution. What you're really looking for is a shift in perspective. And so I might start by kind of, saying, okay, so here's what you just went, here's what your experience is, and reflecting it back. And then to say, if you were in a similar situation with your best friend, what would you think about this scenario? How might you approach your friend? we have this really interesting ability to hold one set of judgments about ourselves and another set of judgments about others. We're much more forgiving towards other people and much more critical of ourselves. So what you're doing there is kind of putting a little bit of a framework in that, where you're sort of helping the person to kind of shift. You feel the same way about other people in a similar situation. And it's actually a very useful thing to do, because then that leads you to asking permission to educate. And here's where you can have a tremendous benefit to your patient, which is we believe that a lot of the education on genetics, on hormonal, neurobiological, counter-regulatory responses, on social determinant issues are actually excellent strategies for framing up a reinterpretation of, maybe this isn't your fault, maybe there's a shift here. And I think that that can be extremely beneficial. There's also something that I call it the grand apology, which is, I do believe strongly that we have to own the fact that we've contributed to obesity bias. So if our patients are experiencing themselves as sort of in a really negative way, we've actually contributed to that very actively in the way that we've been. And if I think about the sort of revised narrative of obesity management as an opportunity to ask permission to provide an education, and really to acknowledge that, to say, you know what, I wonder if you would consider the fact that, you know, up until recently, we've kind of viewed this as a simple problem that was yours to solve. And we've now understood that we had it really wrong. And so, like, I'm really sorry. Like, you know what, I really wonder, are you open to a reframe? Could we start over? And I know maybe I'll stop there, because David has some really useful ways that he does this in his practice. And I think it'd be really useful if you could hear how David approaches that in terms of, you know, the specifics. Can you pick up from there, Dave?
And Michael, thank you for the great summary of the evidence. So I think the question is around internalized weight bias. And just to give you the kind of example from what I would do in my practice, I think there's not a patient interaction that doesn't go by where I'm not reminding a patient the theme of the behavioral treatment that we're going through is that, just a reminder, you know, what you struggle with is a real condition. And we've explained that there's 70% of someone's risk of struggling with weight in their lifetime is conferred genetically. Most of the genes that determine the risk of obesity are in the central nervous system. We each have a unique appetite system. And how we respond to this food environment where we're surrounded by ultra-processed foods and ultra-portioned foods and ultra-available foods, and how we all evolved in a time when calories were scarce and work was required for food. And that everyone is at a different risk, therefore, of struggling with weight. In fact, those who are genetically vulnerable in this environment, it is quite natural to struggle with weight. And so what I'm establishing there clinically, and I really want this point to be very clear, very straightforward. My job in the internalized weight bias module is to help the patient know what I believe. And I believe with great confidence that their struggle is valid and real. And then the next point is that treatment exists. So once we've established that I've communicated that I believe that what they struggle with is real, and it's quite easy to do and to sit with confidence and describe this to a patient. The next point of addressing internalized bias is not only is it a real condition, but it's eminently treatable. We have effective behavioral interventions. And not everyone who's listening today is an expert at providing a behavioral intervention, but there are steps and they can be broken down. And so behavioral intervention exists, and medication can be an adjunct. We have effective, safe medication that can be an adjunct to behavioral interventions. Surgery can be very effective and safe as well. And so I want to introduce this concept. So if I've done my job correctly and the patient believes that I believe that what they struggle with is real, and that I believe the treatment exists, the invitation at this point is for them to consider that these are the cases. And so what is the downside of them not believing that their condition is real or that treatment exists? The downside is Michael mentioned earlier that one of the key predictors of someone's success long-term is their level of adherence to behavior change. And it turns out that if someone believes that theirs is just a matter of not being strong enough, not having enough willpower, just not really being as motivated as they should be, where the cost of that is in this clinical treatment is how someone responds to a setback. And so there's this skill called resilience, which is one of the two cognitive behavioral therapy skills of behavioral weight management, helping someone develop the skill of resilience. What does resilience mean? It means the ability to get knocked down and then get back up again and dust yourself off and move forward in a motivated way. So why is that an obstacle? Why would someone with internalized weight bias struggle with resilience? It's very straightforward. A setback happens, an off-track day, a day maybe they get on the scale and see a number not in their favor. And there will be an automatic set of thoughts that will play in this person's mind that describe themselves poorly and their capacity to manage weight poorly. And that will create a negative emotional state. So thoughts of, oh, here I go again. What was I thinking? This is just like last time. Clearly, I don't have enough willpower. It's never going to work. I'm just not good enough. That leads to emotions of frustration, disappointment, anger, and that leads to demotivation, and that breaks adherence. And so the root, and this is why we put it first, is to sit back comfortably and at least explain to the patient that you're inviting them to consider that their struggle is real, it's a real condition, and that treatment exists. And then you might even, as a bonus, add that, ask them to consider that their past, because that's where all their false negative thinking is about their ability to manage their weight, invite them to consider that their past is actually inadmissible evidence as to whether they can manage weight before, because they've never been treated comprehensively for this real medical condition. That would be a summary of addressing internalized weight bias within a clinical scenario.
Great, thank you, David and Michael. Barbara has a question. She's asking about a gentle and honest way to rein in unrealistic weight loss goals in people with obesity. So what's your response to that?
Yeah, this is again a really important issue. And so you'll notice that in the guidelines, we've included the phrase repetition and relevance. And so Barbara, and I see Veronica, you also have a similar comment here about expectations. And I think it's actually really important for us to be mindful of this. So I would say that what would be really useful is for us to be comfortable with the process of what we call guided discovery. And so here's what we learned from the literature. And I would my first comment to you is don't get stuck on the unrealistic goals. So you know, when we looked at the literature, that's what our first pass at the literature was sort of around this question of, okay, if my patient has really extreme expectations about weight loss, is that going to interfere with their treatment? Do I have to correct their expectations in order to be successful in helping them change? And the evidence is fascinating, because when you just look at that question, does the degree of unrealistic expectation interfere with treatment? The answer is no, it does not. It's not the case that people with more appropriate expectations do better in behavioral interventions, and those with excess expectations do poorly. And then as we dig deeper into it, what we discovered was that the real value is in satisfaction with the goals attained. Now, this is a comment that also applies to life. And what I mean by that, it's not having what you want, it's wanting what you have. And so what I would encourage us to do then is acknowledge the person's expectation. And then, as you've heard with David and myself, the repetition piece is the opportunity not to challenge that belief, not to try to correct that belief, but to hold up. And so what I often do is put one hand up and say, so here's where your expectation is. Would it be okay with you if I shared with you some of the evidence? Put up on my other hand, okay, evidence on best weight, or you know, I like to show the Biggest Loser study, you know, the Kevin Hall study that came and showed 6 years later after the 2009 season of the Biggest Loser, what happened from a weight and a resting metabolic rate to those people who lost so much weight. And then the repetition piece is to sort of just help your patient realize that, okay, these are your goals, which is fine, and I'm supporting you in changing, but also I just want you to be aware of what the evidence is, and it's not challenging. So Barbara, there's where the gentle piece, it's gentle and it's honest and it's non-judgmental. So the patient, the individual doesn't feel threatened. And then the benefit is to focus in on the satisfaction piece, because, you know, that's when you see the person who sort of is ending up to experience their life in a much more rich way. And it can be critically important around the self-esteem issue, because there's something that I just want to say as clearly as I possibly can about self-esteem and self-esteem deficits, which is extremely common in the population of individuals we're trying to help. And that is the following: self-esteem can never be bought. Self-esteem can never be borrowed. It can never be downloaded. It can always be claimed. And so as we sit with our patients and we encourage them to start to benefit from the gains that they've made, and you will see these, we know the curious power of modest weight loss can produce tremendous benefit to function, quality of life, and health that the patient can then translate into immediate gains. And so I would sit with their high expectation and provide an opportunity for gentle education, but also be focusing in on their satisfaction with the goals, because it appears the evidence is fairly clear that if the satisfaction with the goals attained is there, then the behaviors will continue. But I think it's a great question.
Yeah, and I might add one thing to that, Barbara, Veronica, is it's also useful to explore with the patient, what would this do for you in your life? So what would be the impact of this future state? What would your life look like? What would be the things that you would be able to do? And in that way, try to explore and get at the value-based goals that people might have. So there might be something that they really want to reclaim. I'm thinking about one of my patients who I spoke with a few years ago, who really wanted to be able to walk up Mount Robson with her boys, because she had done that as a kid. She'd gone camping. That was really meaningful for her. And she wasn't able to, at that time, even walk on the flat for any length of time. And so translating that into something that really matters for the person, that is a tangible behavioral thing that they can work on and that they can achieve, can really help to build satisfaction and, as Michael says, build self-efficacy. And it gets us a little bit away from the weight number. The other thing with that is, clinically, we never know where a person's best weight is going to settle out at. And there are about 5% of our patients who actually can, with lifestyle modification, their physiology does permit them to lose tremendous amounts of weight. We've all taken care of people who are actually able to do that. And we never know ahead of time which person might be the one that's able to do that. We can guess if they've yo-yoed a lot and they've really struggled, and there's some tools that we link to in the algorithm. It's algorithm 2 in the CMAJ paper, links to a QR code that takes you to some tools where you can flush some of that out, and that will give you a little bit of a sense. But again, we don't necessarily know what number their body's going to settle at. What we do know is that we can help them with those value-based behavior goals, which are really rewarding for people. And it's really gratifying that now, 4 years after that conversation, that patient can walk up Mount Robson. And that's pretty cool. I don't know, David, did you have any thoughts for Veronica and Barbara on that?
Sure, Barbara and Veronica, it's a great subject. The concept is expectations, and I think many of you might want what would be a useful clinical approach to managing this. Michael has suggested we frame the discussions in a motivational interviewing process. And to simplify, we suggest that there's an ask, a listen, a summarize, and then inform, advise. So I'm going to go through those 4 very quickly to show a stepwise address of expectations in a clinical scenario, maybe really over just 2 minutes or 3 minutes. So the idea is, say we asked, you know, have you thought about your goals of how much you'd like to lose? And by the question that we've heard today, maybe the comments were such that it was considered to be a potentially unrealistic expectations. So first of all, I would summarize, and after listening to them describe, I would summarize. So it sounds to me like you were saying that, you know, when you were 18 and you were at this weight, you felt best and you'd like to get back there again. And now remember, the last stage is inform and advise. And so here we're going to invite and inform and invite, pardon me. So here we're going to invite the patient. I'm going to ask you a question. Would you consider that this journey that you're on to manage your weight is in the pursuit of finding what is called your best weight? I'm wondering if you would consider discarding of the phrases of goal weight and target weight and ideal weight. And best weight is really a question you would say to a patient. The question is, would you consider organizing and working on what you have control over, which is your behaviors, and really carving out your most modest lifestyle, maybe even the least that you can take in, but while still very much enjoying and maintaining a loyalty to fun and food and friends and socialization and celebration, and at a level of effort that is sustainable. So would you consider putting together, working on, carving out, that's your journey, your most modest lifestyle that's still enjoyable and maintains a loyalty to fun at a level of effort that is sustainable, and then stand back and watch as your brain and body actually tells you where that sustainable lifestyle lands you. Why? Because that's actually how it happens. Every human weight loss, and most, if not all of everyone, knows the curve shape of a weight loss curve. We know that it starts quick at the beginning, and then it starts to slow and slow and slow, and then it kind of over time pulls in somewhere, often around the 26-week point if they're doing just a lifestyle intervention, not the adjunct of medication. So why does that shape happen? And we can show this shape to the patient. I can say, I actually don't know how much weight you'll lose. Weight's not a behavior. These are the behaviors we can work on. I don't know how much weight you'll lose, but I can tell you the shape, and it'll look like this. And remind them that the reason it takes this shape, because we addressed internalized weight bias, is because the brain fights back against weight loss. It primarily increases appetite, but also decreases metabolic rate as you lose weight, because it's trying to defend you against weight loss. Because our ancestors, when they lost weight, it was never good news. It was because the food supply was interrupted, and there's amazing redundant systems that are going to try to defend you. How strongly? Well, it's much conferred genetically. I don't know how strongly. You don't know how strongly it'll push back. So would you consider standing back and finding out what is the best you can do through behavioral intervention? We can work on this, work on the things you have control over. Weight's not a behavior. And then stand back and find out, you know, where this lands. Very interesting phenomena, you know, when you've done your job correctly. What's fascinating is a patient pulls into their best weight. They're 30 weeks, 32 weeks, 34 weeks in. And yes, all the last 2, 3, 4, 5, 6 weeks, they've been the same weight. And the shape of the curve is as it is. And then the patient, and you know that the level of satisfaction that Michael just said is the predictor of success is happening. Because again, it's a level of satisfaction with where they land that is the predictor of success. You know that's happening when the patient says, you know what, do I want to be 10 pounds lighter? Would I want to be 15 pounds lighter? Sure. But what I've learned to realize that that lifestyle that would be needed to support that lower weight, I'm actually not interested in it, because I actually enjoy my weekends and I enjoy kind of my social life. And sure, I could, you know, drink a weight loss shake in the morning and then a chicken breast and a boiled, you know, spinach mix at dinner. And of course I'd lose weight, but that's not the lifestyle that I want to live. And I see that what I can sustain and still enjoy kind of lands me here. And then that's a home run, because you've helped develop a level of satisfaction. And that's your job, by the way, as clinician. That's what this guideline says on the expectations chapter. Your job is to help them develop satisfaction with where they get, because you know, and we know, and we try to convince them and ask them to, or invite them to consider this themselves, that they don't have control over their weight. It's going to go where it goes when they're doing the best that they can.
As we're listening to David speak, it's interesting. One comment I'll just make is that I hope that we can communicate the importance of the patient-provider relationship. So David is summarizing what, with, let's say, patient A could be a relatively short patient of time, with patient B could be a long period of time. But it's the relationship that you have with your patient that allows you to respect what they're saying without agreeing with it, providing them the opportunity to consider an alternative, and then encouraging them, as David is describing. And so one of the things that we want to come away from is that, you know, obesity management isn't this kind of thing we do to a patient. It really does represent chronic disease management. It's very much in the context of the patient-provider relationship, where your ability to guide the patient over time is really, really beneficial.
Mm-hmm. Great, thanks very much. I'm going to combine Leslie's and Hannah's questions together, which are just fantastic. You know, sometimes there's other things going on with people. Sometimes they've suffered trauma, you know, maybe emotional or sexual abuse. They may have other mental health challenges, perhaps attention deficit disorder or depression, anxiety, body dysmorphia, or they may suffer with alcohol addiction or other addictions, which can make this a good deal more complicated. So when you unpack some of this in your consultations, David, how would you tackle some of this, and then we'll go to Michael.
Sure, it's very straightforward, though the conditions are not straightforward, but the approach to this is straightforward. We're calling this module modulators. And what Michael mentioned earlier is that we have great evidence that the drive to eat, the subconscious wanting and desire and drive and motivation to eat, and our ability to self-regulate against this is not only tough enough, and much is conferred genetically, and this is my conversation with a patient. I'm asking if they would consider that not only is it tough enough, and that's part of this behavioral intervention that we'll be providing, but it actually turns out there are these what are called internal states or modulators that will actually affect or upset the apple cart or make weight management more difficult and make actually restraining over wanting more difficult. And the examples, for example, here we talked about ADD, depression, anxiety. So let's unpack this. We know that, by the way, depression, and all of us know how to kind of assess depression in our clinical practice. I don't know if you guys know this, but depression as a modulator results in overeating and weight gain only about 35% of the time. In fact, the majority of those with depression will, during a depressive episode, lose weight. And appetite will be decreased. And we'll see differences on MRI between these two groups. These are phenotypes. But of course, if we're in a weight management consultation, chances are we're sitting across from someone who lives with depression, who is part of the phenotype where their appetite system is turboed up while they're depressed and their appetite is higher and they're taking in more calories. And so this is, as Michael has said, is about my relationship with my patient. I'm asking, would you consider that this is tough enough as it is, but that your depression can also complicate your capacity to manage your weight? Again, what we're doing is we're not taking the patient off the hook. We're addressing internalized bias. We're helping them understand that their obstacles are real. So addressing both depression and making it a priority of being a component of our treatment. And of course, recognizing that medications that can be used for depression, and there may be in the list that you review with the patient, there may be weight-promoting medications as well, SSRIs as an example. And so there we're addressing this obstacle by bringing it onto the table and helping a patient understand where it fits and how it's real and how none of this is their fault or a flaw in character or a lack of willpower. You have probably a genetic vulnerability struggling with your weight plus ADD plus perhaps early childhood events that created a much higher likelihood of the genes of stress, of anxiety and depression to play out. Stress is another modulator. Sedentariness is another modulator of the appetite system. Check if their sleep is disturbed. Check if there's sleep apnea, of course, which is so common. Check if there's insomnia. This will affect already the hard work that they have in front of them as an internal state modulator. And so it's a finite list, by the way: depression, anxiety, stress, fatigue because of those two reasons, ADHD, sedentariness. Interesting. Sedentariness is a modulator of our appetite system. You can counsel them on that too. Weight promoting medications and going too long without food, the good old classic physical hunger, which doesn't necessarily play in that much. But these are all the finite list, which you'll see will be listed as modulators that you check in on as things that are internal states that can make the work that they're doing even more difficult. So really we're addressing each of them individually but most importantly, having the patient know that these are real obstacles and we understand and recognize them as obstacles. And it's part of them and finding out what's the best they can do with comprehensive treatment, plus or minus the adjunct of medication, plus or minus the adjunct of surgery.
Thanks, David. And Michael, and it's just time, I'm going to ask if you might be able to fold Veronica's question into your response as well.
I will. Yeah, for sure.
Yeah, thanks.
I'll just make a couple of additional comments. First, I would suggest that with, Hannah, don't, the evidence when we even look at serious mental illness, so individuals who would have, schizophrenia, bipolar disorders, extreme obsessive compulsive disorders, there's actually a good deal of evidence showing that behavioral interventions are equally effective with those individuals. So it's very important that we sort of focus in on a relationship with the patient. What are they actually capable of? Sometimes the behavioral changes that people can make, realistic changes that empower and help develop self-efficacy, are actually antidepressing. They're anti-anxiety inducing. So they can actually be really useful. The only thing I would suggest that I find very useful is that sometimes the patient will present with these issues and it's like, well, if only I didn't have this issue, then I could focus on the other issue. And so they kind of offer this as a if only. And for me, what I found helpful is helping to start with if only and trying to end with given that you have ADHD, how can we develop a plan? So that you acknowledge and then look for strategies, sort of shared problem solving that would then allow you to move forward. Veronica, you have a question about the sort of what we sometimes refer to as dichotomous thinking. It's either black or white, yes or no. I'm on top, I'm a flop, I'm a success, or I'm a failure. And sometimes people can get really focused in around that. And perfectionism is sometimes associated with insecurity. I must be adequate. If I've done everything perfectly, then I guess I'm good enough. And so one of the things that again is useful is and think about sitting with. So imagine you say to your patient, I've noticed something with you. You sort of have this attitude like if you don't do it perfectly, it's useless. Does that ring true? And so you and the patient get agreement. So that's kind of your summarizing. And then you kind of keep looking for that pattern and then asking permission to present a counterpoint to that. Would you ever consider being more gentle? Would you take that same attitude? Do you do that with everything, or is this just specific to the diet? Or asking, why do you think you're sort of addressing it in that attitude? And it's those conversations. And this is where I find that it's actually really, really helpful that there are some conditions and circumstances where, you might want to, have a psychologist involved to do the actual treatment. But many of these obesity-related issues, especially the pattern of thinking, can be addressed very well using collaborative problem solving. And then remember, ask the patient when they have that kind of thinking, what impact does that have on them? And this is where those kinds of questions, does it take you closer to the goal that you want to be, or take it further away from the way you want to be? So thanks for those questions.
Thank you so much, Michael, David, and to all of the participants today. It's just been a really interesting conversation. And we really do appreciate your feedback. So there is in the chat box as well as on the screen some links. So please give us some feedback so that we can reflect and improve our session.